Good morning. My name is Raj Gupta and I'm your MC for today's event. First of all, I would like to begin by acknowledging the traditional owners of the land that I'm hosting this event from, which is people of Kulin Nation. I also acknowledge the traditional custodian of the various land on which we all work today and the Aboriginal and Torres Strait Islander people participating in this event. So on behalf of the Mental Health Foundation Australia and the chairperson, Mr. Vasan Srinivasan, I would like to welcome and thank each one of you for attending the Day 8 of Mental Health, National Mental Health Awareness Month. So this month is an initiative to raise awareness of mental health of our community. It's aimed to initiate a nationwide conversation about the mental health through a series of various mental health related events in the month of October. It aims to reduce stigma and facilitate positive and non-judgmental discussion surrounding the important topic of mental health in Australia. Every individual has faced, and many are still facing, unprecedented challenges due to COVID-19 pandemic. It's putting enormous pressure on health system, causing excessive burnout and fatigue among medical professionals. So today's symposium is about mental health amongst medical professionals. Before we start, I would like to take the opportunity to speak something on the topic of healers do need healing, the focusing on the mental health and suicide among medical professionals. Those who don't know me, I'm Dr. Raj Gupta, and I'm a pediatrician at Western Health in Melbourne, and I'm director of Western Specialist Center and president of Healthcare Awareness Society of Australia. Healers do need healing. There's no doubt about that. The public perception is that we doctors are very successful, very confident, intelligent, healthy, immune from the problems of the world. People think mental health issues, fatigue, burnout, suicide don't happen among medical professionals. The reality is this perception is vastly incorrect. Like everyone else, doctors do have usual problems of life. They do get divorced, they have custody battles, they have court cases, they have disabled children, they have family problems, they have issues in form of illness, deaths of the friends and relatives. But what they don't have is the time. They don't have the time to work out their own problem, do the overload of work of 60 to 80 hours or more hours of they work in the hospital sitting and treating patients. In 2013, there was one survey done by Beyond Blue, which showed doctors had substantially higher rate of psychological distress and attempting suicide than other Australians in general. A quarter of doctors had suicidal thoughts, almost double the rate of general population. 21% had ever been diagnosed or been treated with depression. Burnout is a serious problem more among young doctors, those who are in training, and almost half of them in this survey reported emotional exhaustion. In New South Wales, few years ago, 2-3 years ago, if I remember correctly, 2018, 3 young doctors committed suicide. In US, medical profession has the highest suicide rate than any other profession, and 1 doctor commits suicide every day, which is on an average is twice the rate of general population. Female health professionals are at twice the risk of suicide than women in any other profession, and men are generally 3 times more likely than women to die by suicide. So suicide is an occupational hazard in medicine. Doctors on job do get post-traumatic stress disorder, especially those who are working in emergency medicine and in intensive care. Patient death, even without any medical error, may lead to self-loathing. Humans do make mistakes, and in general population, these mistakes may not carry significant consequences on them. But however, when doctors make mistakes, They are publicly shamed in the court, on social media, on television, and on newspaper. Doctors carry the guilt of this unintentional mistake for the rest of their life. And if doctors seek help for their mental health, they risk being disciplined. The fear of temporary withdrawal from the practice, the fear of lack of confidentiality, the fear of not maintaining privacy in the treatment, the fear of loss of respect in the community are often the major impediments that hinders physicians from reaching out in a time of crisis and seeking effective treatment. When doctors renew their medical registration every year, they have to answer many questions regarding their mental health issues. Physicians with mental health issues, they always fear their practice insurance, the medical insurance, life insurance, disability insurance can be denied. And because of all these reasons, doctors indulge into self-treatment, and too often the self-treatment is unsuccessful. And failure to obtain consultation and treatment for depression needlessly and significantly increases the risk of physician suicide. In my view, suicide is preventable in any profession if we stop the secrecy, stigma, and punishment. And in absence of support, doctors make impulsive decisions to end their pain permanently. The pre-COVID burnout rate in medical profession was around 40% in one survey, and it is predicted to increase to 68% in post-pandemic. So you can guess here what the medical professionals' mental health is going to be after the COVID, and particularly what's happening in emergency and in the ICU of Victoria and New South Wales. Washington Post had said the USA, there are many people in medical profession, they are resigning from their job. And it is estimated by 2032, USA will have the major shortage of doctors and nurses. And unfortunately, we in Australia are at risk of this rate too. We are focusing on revitalizing our economy rather than well-being of our healthcare worker. Despite knowing the fact that the burnout and unsupported physical and emotional exhaustion will result in healthcare system collapse, where economy will collapse anyway. So there is an urgent need to intervene to protect and to improve the mental health of medical professionals. The intervention needed to target not only to individual, but more importantly, the organization and the wider system where they work in. So we can reduce the mental stress, burnout, fatigue, and reduce the suicide rate amongst medical professionals. After all, healers do need healing too. Thank you very much. Thank you, everyone. Before we continue and listen to our fellow speaker, please join me in celebrating the work of Mental Health Foundation Australia by viewing this short video. Video, please.
Hi everyone, I'm Vasan Srinivasan, Chairperson of the Mental Health Foundation Australia. It's a privilege to lead this wonderful community-based mental health organisation in its 91st year of establishment. The MHFA has grown strength to strength over the past few years, with Victorian Mental Health Month in 2018, the National Mental Health Month occurring in 2019, 2020 and this year in 2021. Last year, COVID-19 did not stop us from achieving our National Mental Health Month campaign. I'm proud to say we successfully shifted many events to a virtual platform, very much being able to pursue our objectives of raising awareness and advocating for better Australian mental health. Our primary aim is to reach out to and educate as many Australians as possible, to help reduce stigma and to encourage constructive and non-judgmental dialogue on Australia's critical mental health issue. The highlight of last year's campaign was reaching out to 100,000 Australians all across the country for our National Walks for Mental Health, both virtually through our MHFA app and physically in some states. What a grand success that was. In 2021, with pandemic still affecting many of us, we decided not to give up once again, curating a carefully chosen blend of virtual and physical events for Australians to participate in. This year, we have a new and improved MHFA app, giving people the opportunity to participate in National Mental Health Month from the palms of their hands. This year, theme is mental health and post-pandemic recovery challenges and resilience. Mental Health Foundation Australia is proud to partner with Australian technology business DB Results and take up the well-being app Am I OK? To support our members, enabling individuals to regularly check in on a private and secure platform and ask the question, Am I OK? Am I OK also alerts the user when it's time to seek outside help. We thank DB Results for this opportunity to promote well-being and early intervention. This year, we have launched a special initiative, the Mental Health Appeal on the 10th of October, our World Mental Health Day. Through this, we aim to raise funds for the development of a course promoting life and safety in young people. At the MHFA, we pride ourselves in making sure all our programs are for the community and powered by the community. We have a vast growing network of multicultural ambassadors, youth ambassadors, and future leaders who further the community voice in promoting mental health and well-being. Our multicultural network has inspired our educational and multicultural webinars as an initiative to assist individuals cope with success during the pandemic. I would like to take this moment to thank our board directors and patrons, scientific advisory committee members, our wonderful staff, multicultural and youth ambassadors, future leaders, MHFA members and major sponsors for their continuous support to our organization as we continue to work to deepen understanding of the importance of mental well-being and educating the community. Let's work in solidarity for the benefit of our mental health. Thank you, Australia.
Thank you. Now I would like to call upon Professor Bruce Tong, who is a patron of Mental Health Foundation Australia. Prior to his retirement in 2012, Professor Tong was the foundation head, School of Psychology and Psychiatry, and head of discipline of psychological medicine at Monash University. He was also the senior clinical advisor of mental health program of Monash University. Please welcome Professor Tong.
Thank you, Dr. Killen, for your introduction and for chairing this important seminar. This year, the Mental Health Foundation Mental Health Month focuses on promoting mental health and building resilience in the face of the stress and challenges of the pandemic. We acknowledge the traditional owners of this land and pay our respects to their elders, past, present, and emerging, and their communities. I welcome all Aboriginal or Torres Strait Islander peoples joining us today. I recognise that they have faced long-standing challenges to their mental health and well-being. The Mental Health Foundation Australia is the oldest not-for-profit community mental health organisation advocating for better mental health in Australia since 1930. We've been working in the community for over 90 years promoting mental health, especially in multicultural communities through our extensive network of multicultural community leaders. This year, our Mental Health Month program is open online to all and includes a celebration with song, dance, artwork, creative writing and exercise, particularly our National Walk for Mental Health on the 17th of October, which you saw depicted in the video. Our symposia, forums, expo and summit cover topics across the age spectrum and focus on specific challenges facing many peoples from all walks of life. Indigenous, multicultural, refugee and gender diverse communities, family and youth. The sessions originate from all Australian states and territories. I also encourage you to attend the World Mental Health Day Summit this Sunday, 10th of October, with significant contributions from international experts, mental health policymakers, and those with the lived experience of mental health challenges. On that day, the Foundation will launch the Mental Health Appeal. More information can be found on our website on this appeal. Today, as part of our extensive program, we discuss a vital and important issue: the mental health and well-being of Australia's dedicated mental nursing and health services workforce, who are currently labouring under extraordinary pressures, challenges and stress due to the pandemic. This occurs in all health settings, not only the frontline emergency intensive care services, although they're particularly impacted. It has been demonstrated that this precious workforce experiences significantly greater mental health challenges than previously. Importantly, this also impacts their partners and families. Not surprisingly, they remain reluctant to seek help due to their commitment and altruism, but also due to consequences of persisting stigma. Many cope with these challenges because of their training, peer group support, and knowledge and application of taking protective measures, including vaccination. Nevertheless, the majority experience fatigue, mood swing, and repercussions at home and in family life. Today, we will hear of the best approaches to support this essential workforce, both in their workplace, but also in their private life, which recursively will build resilience. I now, with great pleasure and thanks, welcome our speakers, Ms. Elizabeth Koff, Science Chair Professor Helen Christensen, Professor Peter Barlos by recorded address, Associate Professor Teresa Jacques, Dr. Tony Sara, Dr. Chris Dalton, and Dr. Rava Camasetti. Welcome and learn and take heart from this seminar. Thank you.
Thank you very much, Professor Bruce. It was a very insightful message. And now I'd like to invite Ms. Elizabeth Koff, who is the Secretary of New South Wales Health. Elizabeth has held a number of senior executive roles within New South Wales Health System, including Director, Clinical Operation, South Eastern Sydney Illawarra Area Health Services, and Chief Executive of Sydney Children's Hospital Network. As a Secretary, Elizabeth is committed to strategically reshaping health services to provide better value care and improved patient outcomes, ensuring New South Wales continue to lead the nation in delivering high quality care to its community. Please welcome Ms. Elizabeth.
Thank you, Raj, and thank you for the opportunity to provide a very, very short welcome to the Medical Professionals Mental Health Symposium. And at no other time has this been so important from my perspective as leader of the New South Wales health system. At no other time in living memory have health systems across the country been under such sustained pressure as nearly the last 2 years have shown us. And that pressure is personal, public, and even political pressure. And it has a heavy burden on many, many people across the health system. And we've spent 2 years attempting to protect and treat the population for COVID-19. But the most important thing about our health systems, they're only as good as the people who work within them. And obviously from the New South Wales perspective, it's been an extraordinary effort of every single person in the New South Wales health system. But I'm fully aware of the consequences of that enormous effort and stress and pressure will have a personal or currently has a personal impact. And there are consequences of that that we can't ignore. We've spread ourselves so thin for so long, and the added imposition of COVID on top of that has really stretched us really to the limit. And that's what we need to be careful of. Just a couple of quick reflections on the journey that we've had. And reflecting at the start of the pandemic, staff anxiety and fear was running extraordinarily high. We were looking at what was happening in Europe, the Italian settings, the French settings, and the number of representations I had from clinicians saying we need to stop conducting non-urgent surgery, we need to prepare for this, we need to procure PPE. the level of fear and anxiety was very, very high. And we worked very hard last year to engage the medical workforce, the nursing workforce, the allied health professionals, of how we could empower people to feel as if they did have some control of what was happening within their facilities. As we're currently experiencing the Delta wave here in New South Wales, the anxiety and pressure of what might overwhelm our ICUs was absolutely palpable. The modelling, the numbers that could come through our front door placed extraordinary pressure on people as to what they could anticipate, but then also the pressure of treating the patients. And whilst Raj mentioned it's not only in ED and ICU, the whole cadence and operation of the hospitals has been disrupted with the way we've had to deliver care. And the burden of responsibility on staff, with visiting restrictions imposed on loved ones who could not come and visit those we were caring for, was absolutely extraordinary. Everybody is fatigued, and that's my big concern going forward, that the pressure and stress of what we've endured will have consequences and impact. And the remarkable thing about the health system, it is resilient because it has a passion to deliver the care that it does, but it's not sustainable for us to continue on as business as usual. Some things need to happen, and we need to protect and ensure the resilience of our healthcare workforce, because without the workforce, we don't have a health system. So for the future also, I think we're going to have a shift, because we will be living with COVID for a long while yet. And how we start reintroducing care, managing deferred care, because we're very conscious of the fact the surgery cancellations, the diagnostic procedures that have not been undertaken will result in a high level of demand for health services going forward, whilst we still continue to manage COVID. And I think we need to be pragmatic about how we can deliver that care and please the community and the politicians, but also ensure the welfare of our staff. And I'm really pleased that you're having this forum, and I'd willingly accept the feedback as to how we as a health system can accept that advice and take some undertakings. We've established workforce wellbeing collaboratives with key stakeholders. We've got COVID welfare teams that support some of the staff. We've tried apps and we've had phone lines and multiple strategies. But I think from what we've experienced to date, and as Raj identified, many people don't want to engage with support in that area due to their unwillingness as to the implications of seeking support and welfare. And if we can encourage clinicians to really engage in a meaningful way with the range of supports, and if we can deliver a wider range of supports, we'd be more than willing to hear your expertise and advice. So I thank you for progressing this forum today, and I welcome the feedback and initiatives and thoughts that can assist us from the health system management perspective in supporting all our clinical staff. And a thank you from the bottom of my heart for all clinicians involved in the management of COVID. It's been absolutely extraordinary, and I think we as a country can hold our head high. Thank you.
Thank you very much, Elizabeth. Thanks for joining us today, and it's been a pleasure listening to you. It was a very thoughtful message. And in fact, I'd say it was a very comforting for the medical professional community. And as a token of appreciation, a small gift from the foundations will be sent to you. Thank you very much.
Thank you.
So now it's my pleasure in welcoming our keynote speaker of the day, Professor Helen Christensen. Professor Helen has been Director and Chief Scientist at Black Dog Institute and Professor of Mental Health in University of New South Wales. Professor Christensen is a leading expert on using technology to deliver evidence-based intervention for the prevention and treatment of depression, anxiety, suicide, and self-harm. Welcome, Professor Helen. Over to you.
Thank you. Thank you very much for inviting me to speak today. I'm really excited to be here, and I think it is such a timely seminar, given the fact that we're about to have so-called Freedom Day and the enormous pressure that's likely to bring to our health services. Next slide, please. So my presentation really is on the effects of COVID on the mental health of health professionals and also what we can do about it. But first, on the next slide, I'd just like to acknowledge the Indigenous community. I'm on Gadigal land at the moment. I want to recognise the continuing connection to land, water and communities of Indigenous people and pay respects to Aboriginal and Torres Strait Islanders, elders past, present and emerging from all nations across this country. Next slide, please. Okay, so I've got 15 minutes and I'm not even sure if I'm going to speak for that whole 15 minutes because I think many of the topics have already been raised by our earlier speakers. I'd also like to acknowledge the work that's being done by the Mental Health Foundation. And I had no idea that you guys have been around for such a long time and it's wonderful to see it continuing. Okay, so what am I going to do today? First of all, 4 quick points is really the guts of what I'm talking about. The first is, what do we know about the mental health effects and risk factors for mental health professionals during COVID? What is the data, or are the data actually telling us? Secondly, I wanted to look at a couple of things that are being offered to health professionals to assist in this process. The first are individual opportunities for health professionals to take up. And then secondly, to look at what can be offered at the organisational level. And I think Elizabeth Koff has really pointed out, working within the organisation of the massive New South Wales Health, what the pressures are in our organisations, and also looking to what is going to happen into the future, because even though we're going through this terribly stressful time at the moment, COVID is still going to be around. We're going to have the continuation of psychological and other distress arising from climate change, from bushfires, and also just the normal and continuing impacts that changes in our health conditions are having on the structure of health organisations at the moment. And is this an opportunity to really think about doctors' health, nurses' health, other health professionals' health, in the context of this, this climactic change that's happening with COVID. So first of all then, what do we actually know about the psychological effects and risk factors of doctors' health and nurses' health, health professionals' health during COVID? Well, first of all, the international data suggests that depression, anxiety, psychological distress are raised in frontline workers. The rates vary from anything from 10% to 50% for depression and 15 to 44% for anxiety. And this is a large number of international trials that have found this. So what makes it worse? What are the risk factors found for these distresses as a result of COVID? Inadequate PPE, fear of infection, heavy workload, younger age, and being female have been identified as the potentially strongest risk factors for anxiety and depression. And the risk factors for suicide are similar. They're greater for nurses than doctors. They're greater for women than men. Frontline workers, those at the coalface, they're greater for compared to other health professionals, most of whom have been impacted as well. Younger staff in areas with higher infection rates. Well, what does the international literature say about protective factors, PPE? And remember how that was such a big factor 18 months ago. But more than that, it's the views of the community, the organisational support that is provided to health professionals, as well as the individual adaptive orientations that people take. So I can see here that if we think about those protective factors, there are things that can be done at both an individual and organisational level. Now, what do the Australian data show? Is there anything different about the Australian data? And there's been 3 or 4 studies, most of them cross-sectional, but basically they are very consistent to the international data. So 25% reporting psychological distress, nurses and midwives compared to doctors more affected. Those in direct contact with COVID have higher anxiety scores. And protective factors that have been described are the services response to the COVID and how they are looking after their staff, as well as social support from family, friends, and the community. In October last year, there was a large study on moral distress, and it was reported that moral distress related to, as you can imagine, resource scarcity, which is something that many have experienced, wearing a PPE. But clearly, as mentioned already by Raj, the ability of healthcare professionals to care for their patients, the exclusion of family, which goes against their values during times of extreme mortality, I guess, and fear of letting co-workers down if a co-worker becomes infected. Highly protective factors was feeling supported by the public. And in August, just recently, another study of nearly 1,000 healthcare workers reported the 5 challenges to work in these COVID times. And they reported, firstly, work-life imbalance. Secondly, following orders, caring for patients, unpredictability and disruption. Thirdly, the right to be safe at work. And another factor was unpreparedness to work. So if we go back to these 4 quick points, what do we know about the mental health effects and risk factors during COVID? We know quite a bit. We know a lot internationally. We know a lot in Australia now, and there's a very consistent pattern emerging. So what can we do? So the second point here is what can be offered during this period at an individual level. Next slide, please. One of the things that Black Dog Institute was asked to do during the COVID crisis was to see if we could set up an intervention for healthcare workers. Now, it's not an easy thing to do for the reasons that have already been pointed out around the stigma associated with seeking help, the sense of being resilient internally and not needing help. So we developed this along with a number of other universities and groups, and it's called the Essential Network. It's available on our website. It's a bit different in that privacy is maintained, any access to services avoids notification to AFRA. It draws on the strengths of a number of organisations already operating in this area. And the way that we've presented it has been through both an app and also through a website. And we've learned in the last 18 months how to, I guess, encourage people to proceed through the website. So rather than talking about mental health problems, we're talking about supporting your team, looking after yourself, looking after your family, the things that actually matter to mental health professionals. Essentially, it consists of information, self-assessment, access to evidence-based digital programs, support and links into peer-to-peer support as through organisations like Hand in Hand, access to health professionals such as psychiatrists and mental health psychologists through the 2 major industry organisations. And it ultimately also provides access to the Black Dog clinics, free, no registration, as in notification, which we found was one of the most important factors for that really is a barrier to doctors and others seeking help. Next slide, please. This is the data that have come that have told us quite a bit about what we're seeing. So in the last year or so, there's been about 5,000 or 6,000 people who have downloaded the app, which is available in the App Store. Around 44,000 people have come to our website. Around 7,000 people have done online assessment and received referral. And ultimately, 83 people have come through a process where they've elected to actually speak face-to-face with a psychologist or a psychiatrist. When I say face-to-face, it could be telehealth or it could actually be face-to-face. But the other interesting things that came out of that, which you can see at the bottom if you're able to check those data there, that people prefer the website over the app. They much prefer to do the self-help as opposed to actually go through to a health professional. There is checkups that are accessed, and most importantly, the blue lines down there show that most of what you can see there is that people respond during lockdown. So we're getting a lot of people coming, as you can see, at different time periods, but it does actually reflect the changes that are happening within lockdown. And finally, if you can see that last histogram there, it basically shows who uses the website, and essentially nurses, and then psychologists, and then doctors, and so on all the way down. So it's used by a variety of people, but again, it's reflecting the fact that nurses and generally women-dominated industries are using these kind of services more. Next slide, please. Now, the second thing that can be offered is not so much directed at an individual who seeks out help through a variety of mechanisms, as I've described before, but it's what can be done in organisations, because as we saw from the risk factors, it's how the organisation responds to COVID, how the public perceives people, what sort of support is given externally to frontline and other workers. One of the first things that we have found has increased, and which we really think is important, is workplace programs offered to organisations to improve mental health. So it's having managers within organisations knowing how to deal with the mental health and stress reactions of staff. That is a critical structural element that's really required in response to COVID. And I know, having spoken to some of the managers within the hospital system, and the managers themselves are feeling stress, but in addition to that, they feel very strongly that they don't have the right skills to be able to respond to their workers. And by that, I mean not do face-to-face therapy or do any sort of therapeutic intervention, but just how you actually handle this within your teams. And so I think, first of all, mental health training within organisations for managers is a key element, and certainly the evidence shows from what we've done that this results both in improved mental health outcomes but also increased productivity. It's a really important thing to do. The second thing I'd say, and it again links to what Elizabeth Koff was saying, which is how can organisations and service organisations, when they're being put under the pressure of having to respond to so many unwell people, what can they do at an organisational level to look after their most precious asset, which is their staff? And I guess if we look at the risk factors, I would be saying that things that could be being done, and probably are being done, but whether they should be done more, is obviously the promotion and support of frontline workers, the engagement of the community as a kind of movement in supporting frontline workers. This, we know from the risk factor studies, would work. And I think also effectively showing that they do value their workers and the sacrifices and stresses that they and their families have undergone, and that how they have had to step up to the challenges, and how people are leaving because those challenges are too hard. So I think we need to be looking at what the rewards are that frontline workers would like to see, the real compensation that we could offer or organisations could offer to those frontline workers. So I mean, I have my own views about what that could be, but I think it's something that no doubt is being considered by our health organisations. And the next slide, please. Okay, so my final slide, I've sort of described what the risk factors are and the data. I've looked at individual responses and what can be done during 10, tried to think about organisations and the key things that could be done now to improve the outcomes for health professionals. But I think we have to be looking to the future, and it's a problem that's not going to go away. Stigma doesn't change overnight. Hospital systems don't change, so they've all been disrupted in every way. Everyone's positions changed as a result of what's been required to be done in the ICU, etc. But I'd just like to call your attention very briefly to this paper that was written by Sam Harvey, Professor Sam Harvey from Black Dog Institute, and a number of other professors from the University of New South Wales. Just came out in Lancet Psychiatry about 3 weeks ago. And here, I won't go through it, but is a model for what we should be doing in the pre-education of our doctors and nurses, what the hospital should be doing organisationally to improve the health of health professionals, what can be done by organisations, foundations such as this one and others in supporting the health of our health professionals. And as I say, I won't go into it because we don't have time, but I'd really like to call your attention to it, both as individuals and as organisations, to think about the long-term structures that need to be put in place to improve mental health of our health professionals over time. So thank you very much for inviting me to speak, and I look forward to the rest of the program. Thank you.
Thank you, Professor Helen. That was a very, very thought-provoking and knowledgeable speech. Thank you very much. And now I would like to call upon Dr. Peter Barlos. Peter Barlos is a director of Mental Health Foundation Australia. Peter is an internationally recognized interventional cardiologist with the Northern and St. Vincent's Hospital in Victoria and professor of medicine in University of Melbourne. Unfortunately, due to his work, he cannot be with us, but he has sent a short video with his message. So let's start the video, please.
It's good to be with you. It's Peter Barlos here, cardiologist and a very proud board director of the Mental Health Foundation Australia. And I just want to say at the outset that what an amazing beginning to Mental Health Month it has been, and congratulate the organisation and our chairperson, Vasan, who has done a phenomenal job at advocating for the importance of mental health and well-being. And no doubt this is a very, very important topic and close to my heart. No puns intended, obviously, as a cardiologist, but this the theme of mental health and well-being amongst healthcare professionals is a critical one. Now, we are all served and we all do our job in the community to provide excellent quality of care for our patients. But of course, we must know that we are all human. We are not immune to the issues and the same challenges that are confronting our patients. Whether it be anxiety, whether it be depression, burnout, substance use, all these factors remain very, very prevalent, unfortunately, also within healthcare professionals. The pandemic has brought several challenges. Challenges, no doubt, in terms of the resourcing available, the risks of infection, the risks of variants of the virus, the risks of having perhaps inadequate personal protection, and the anxieties this creates. So all these challenges are very real, and I believe what the organisation is doing in terms of bringing it out and discussing it in an open forum is one of the best ways to actually ensure that we can tackle this very important challenge amongst healthcare professionals and ensure that we, as the professionals, can continue to do our job and deliver excellent and high quality care to our patients. So again, thanks very much for being part of this forum and for discussing this very, very important topic. And I'm sorry I couldn't be with you today, but unfortunately duty has called, and I'm required to be in the hospital this morning. But again, thanks again for all your support on behalf of the Mental Health Foundation Australia. Bye for now.
Thank you very much, Professor Peter Barlos. So now I would like to invite Associate Professor Teresa Jacks. Teresa is a director at Mental Health Foundation Australia. Teresa is an associate professor at University of New South Wales and recently retired as Director of Intensive Care at St. John's Hospital. Teresa was awarded with multiple accolades for her incredible clinical research and leadership work. Please join me in welcoming Professor Teresa Jacks. Over to you, Teresa.
Thank you, Dr. Raj. Can you hear me? All good?
Yep.
I'm directly involved in caring for the sickest patients with COVID and their families. And I thought I'd share some personal insights into the challenges healthcare workers at the front line are experiencing and the physical and mental strains we are experiencing in our daily working lives. Firstly, I would like to read an email sent to the ICU staff by one of my senior colleagues who had just come off their grueling COVID shifts. And in my experience, these shifts are grueling and exhausting. We used to do 7 days in a row, but when you're on the COVID pod, 3 or 4 days is the most you can endure. They wrote, "Dear colleagues, I want to extend a personal thank you to all the ICU staff for the last few days. The COVID pod had been at capacity and the acuity is noticeably higher compared to when I was there a month ago." Another colleague puts it very nicely that being in the COVID pod feels like you are being sent to the moon. You are handicapped in all your senses with your personal protective gear. You are extremely isolated from immediate help and asked to look after patients with a disease we don't yet know a huge deal about. She goes on, "Having reflected on the last few days, I realized I too was scared. I was scared when a COVID patient blew up in subcutaneous emphysema, that's a hole in the lung and air all over their skin. I too was scared when faced with proning or turning a hypoxic patient with a BMI of 58, that's very big. I know we all are scared, but seeing everyone's can-do attitude and willingness to do something we're all uncomfortable with without hesitancy is actually what gave me the courage to go ahead and do them. You guys are an amazing team. So thank you to my little moon family. The community will never fully understand how much you've done and sacrificed for them." That's the end of the email of thanks. And my colleague has alluded to the challenge of working in PPE. You rebreathe your own carbon dioxide and you can suffer headaches and nausea, and you can't stay in the COVID pod for more than a few hours at a time. You are indeed very isolated, and that extends when you go home. You are separate from your family and friends and have to have regular COVID swabs until you can be sure you are not endangering your family. If you live alone, you cannot tap into your usual social supports. Waiting for the results of your COVID test is an anxious time. It affects your sleep patterns. Within the COVID pod, you are caring for patients who cannot have families with them, and the families often take out their frustrations on the staff when they ring in. Some of the abuse has been terrible and staff members have been in tears. You and your team provide the comfort and support to patients in the absence of their families, as well as the day-to-day clinical support in ICU. You may be even providing compassionate support as someone is dying, separated from their loved ones. Compassion and empathy fatigue is a real issue, as there is simply no downtime. You have to be on constant alert to avoid infection control breaches. You take your meal breaks alone. Time is short to do all the things you have to do in each shift. And when you get home, it's hard to leave work behind you. It's a very different healthcare world than we were trained for. But as my colleague alluded to, your COVID team that you are part of is simply the best. Not just my ICU team, but all the other specialties that have moved out of their comfort zone to help us. For instance, orthopedic trainees helping to turn patients, cardiothoracic or surgical trainees acting as ICU RMOs. And in spite of the challenges, it is so rewarding to be part of that team. This week, I've been attending the European Society annual scientific meeting. It was held in Vienna, but sadly, I attended it virtually. Healthcare workers from around the world were sharing their COVID experiences, and there were common themes. Fatigue is setting in. Staff experience grief from seeing so many patients die. They fear infecting their loved ones. And across the globe, as has already been alluded to by several speakers, burnout and mental exhaustion are real. There was a paper presented in Vienna from France, a staff questionnaire to French ICU staff. It had a 70% response rate, which is an amazing response rate for any questionnaire. It's usually under 50%. And it tells me that healthcare workers wanted to give feedback and be heard. And these were the statistics. 60% of them experienced anxiety. 40% had symptoms of depression, and 30% had post-traumatic stress disease symptoms. 45% had symptoms of severe burnout. In France and the UK, staff are leaving ICU during the COVID second wave they're experiencing. And now their ICUs have a significant number of very young and inexperienced staff, putting extra pressure on the senior staff who remain. And I cannot imagine what it's been like for my colleagues like Peter Barlos and others in other specialties, the stress they've been under because they cannot access the health system for their patients because COVID has taken over. Non-COVID treatments are being delayed. I call it collateral damage, COVID collateral damage, and the pressure on our ICU beds to squeeze in a few urgent, very urgent surgical cases and that when we've got 2 COVID pods going has been unbelievable. So I foresee a post-COVID challenge of caring for and supporting our healthcare workers in Australia. We should not overemphasize personal resilience, and I don't want that to become the buzzword, but provide them with the opportunity for some downtime, taking some of their accumulated leave and providing them with access to confidential and anonymous mental health support. And there was a paper in the New England Journal of Medicine recently which was talking about studies that show that we in the medical profession prefer to seek help from our peers and definitely anonymously rather than tapping into public support or formal support things. We need to let healthcare workers that it's okay not to be okay and it's okay to seek help. Thank you.
Thank you very much, Professor Teresa. It was a very sharp, sensitive, and truly reflective speech. It reflecting the true life of medical professional, and it further stresses the importance of how important to look after the mental health of medical professional. And time is now, and we can't afford to lose our medical health professionals for their fatigue, burnout, leading into the suicide or other bad thoughts and ideas. Because medical professional, in my view, cannot be trained overnight. It takes nearly 15 years plus of hard work and collective around $1 million of family, friends, and from the government itself to train one consultant. So we can't afford to lose medical professionals. So money spent on the mental health of medical professional is the worth spent money, and time is now. Thank you very much for that, such a sensitive approach and sensitive speech. Thank you very much. And now I will call Dr. Tony Sarah. Tony is a Federal Vice President, Australian Salary Medical Officers Federation. The Australian Salary Medical Officer Federation, in short called ASMOF. ASMOF is the Australian trade union representing salary doctors. The exists to promote the broad interest of Australian doctors, represent their members with employers, advocate and develop quality health services. Please welcome Dr. Tony Sarah. Tony, over to you.
It's the phrase for these days is you're on mute. And I'll just get my speech notes in the correct screen. So thank you, Dr. Raj. Thank you and the MHFA, including Dr. Jacques, for the invitation to speak to this important forum today. My name is Dr. Tony Sarah, and as you've been told, I'm the President of ASNOF New South Wales, the state union, and also the Vice President of the Federal Union. We are the New South Wales and Australian Doctors' Unions, and our members are salaried medical practitioners from interns to senior staff specialists working across New South Wales and Australian public health services. I'll start by acknowledging the traditional custodians of the lands in which we are meeting and pay my respects to elders past, present and emerging. Thank you again for this opportunity to talk today about mental health in the medical profession and the challenges faced by doctors, including the very current challenges we face as a result of the COVID-19 pandemic, which I think the public health doctors are saying will become endemic in the weeks to come. So challenges faced by doctors. It's very well established that doctors are at significantly higher risk of mental illness and suicide than the general population. The primary risk factors for depression and suicide in medical practitioners are work stress and burnout, and the groups particularly at risk are young doctors, Aboriginal and Torres Strait Islander doctors, and female doctors. These groups report the highest rates of stress, burnout, and suicide. There was yet another young doctor suicide just last weekend, which I learned about as the President of the State Union yesterday. From the partner of that young doctor, that young female doctor. It's just terrible, heartfelt. I don't know. What are we as a profession going to do? What are we as a health system going to do? Okay, that's the speech notes, I'm sorry. In these discussions on mental health in the medical profession, we need to firstly recognise that mental health is a workplace health and safety issue, and that doctors have a right to a safe work environment. Earlier this year, ASMOF successfully campaigned with other unions to protect workers from mental health hazards by regulating psychosocial hazards the same way they do physical hazards in the workplace. So there's been a change in the processes and the policies around workplace health and safety. Federal and state governments are finally on their way to recognising that safety at work is much more than the physical hazards that we are often routinely trained to identify as risks. So in our workplaces, we also need to pay attention to stress, long working hours, fatigue, bullying, discrimination, harassment, as these are all risk factors for poor mental health. Many of these dangerous working conditions are part of the culture of medicine. They've been embedded into our medical profession for generations. Many young doctors, including myself, were exploited by that medical culture that takes their ambitions and dedication to patient care and pushes them to their limit. And that clearly is the case, particularly for our junior doctors, who we know are working too many unsafe hours and have been so for decades. The 2020 Hospital Health Check survey found that 51% of doctors in training were worried their fatigue could lead to clinical error, and 44% were concerned about their personal health due to fatigue. These factors of overwork, understaffing, stress and fatigue also impact senior doctors who are increasingly asked to do more with less. These stresses have been amplified by the COVID-19 pandemic. The survey we as a union conducted in New South Wales last month had 813 staff specialist responses. That's around about a third of the members responded to that survey. 59% of those senior doctors are working increased hours due to the COVID-19 crisis, in some cases up to 20 hours more per week. And 85% of doctors said they were concerned about their fatigue levels and mental health wellbeing arising from the pandemic. We've raised that with the Ministry of Health. I won't tell you the response But the fact that I'm not telling you the response probably tells you that I might have imagined that was an unsatisfactory response. That's, I guess, the frontline doctors. Now, for the working from home doctors like myself, no face-to-face interactions with colleagues, with other staff. I just work for the government, and I eat and I sleep, and a bit of television. There is no work-life separation. There's certainly no balance between work and life. I sit at this desk and I just do stuff for the government, for my employer, for the various professional groups that I'm a part of. I'm looking forward to this going back to some sense of normality and having a rest. So, as a union, workplace safety should be our bread and butter. During COVID-19, we've continued to represent and advocate for doctors across hospitals and at state level with regular meetings with the Ministry of Health. We've been very clear that doctors and other healthcare workers should not have to go to work fearing that they might get sick or spread the virus to their families and the broader community. We have campaigned to ensure that hospitals minimise the risk of exposure from COVID-19 so far as is reasonably practical through tools such as adequate personal protective equipment and fit testing as well as proper staffing. PPE was a real challenge. Inadequate supplies, inadequate knowledge about how to put it on, how to do the fit testing. Inadequate knowledge about transmission. Was it droplet or was it aerosol? That has changed a bit with time. The initial virus was probably more droplet than aerosol, but the virus now is easily spread by aerosols. But if you don't have the proper PPE, it's very hard to prevent the spread. So there was a significant bunch of reasons for the large amount of anxiety in frontline health workers, doctors and nurses. We saw the television images from overseas in Italy and New York of thousands of bodies, mass graves. We saw the bodies in corridors. We received the news about hundreds of doctors and nurses dying from this work-related disease. Many, if not most, due to putting themselves at risk without adequate staffing and without proper PPE. As a union, we put on a COVID seminar and we got to hundreds of names of doctors and nurses who had died in New York and Italy. It was just staggering. It was just awful. As a health system, we had never followed the Australian standards for PPE in any health environment or hospital anywhere in Australia. We hadn't had this sort of disease that was so easily transmissible. So as a system, as a health system, we had to make that happen. And ASMOF and the Nurses Association and some of the colleges, particularly the Emergency Medicine College and the Anaesthetic College, assisted to force that change. The supply lines, of course, were inadequate. You know, China was unable to be the normal supplier. So much anxiety, much hard work on behalf of the health system to get the PPE supplies there, to train staff how to use it. And so the anxiety was real. I mean, I had colleagues emailing me and ringing me, and I could feel the fear in their voice. It was just terrible. So more lately, as part of that work health and safety push, we supported mandatory vaccination. The vaccination rates for doctors in New South Wales Health is up around the 98, 99% now. We've only had 2 resignations from our union due to our position on mandatory vaccination, which means that the profession understands it, that our colleagues get it. Vaccination saves lives, significantly reduces the risk of transmission, and it just about guarantees that if you get the disease, you won't be hospitalised and you won't die. 98, 99% protective. So let's look beyond the pandemic though, just for a minute. We need to transform the profession for future generations and end the culture of exploitation of doctors in training. That is why ASMOF New South Wales is currently preparing to sue the New South Wales government for wages theft. That's a bold step. This has not been publicly announced, and I'm not looking this become a press event, but we need to change the culture of medicine. And one of the steps we have available to us is the award. We've had years of broken commitments, years of promises, years of breaches of the law of the award that have put doctors and patient safety at risk. Our priority, our aim, is to change that award to better reflect contemporary work practices, better support young doctors, and we're going to do that by suing the government. So I've taken up a lot of your time. I'm sorry I get a bit emotional about young doctors and the way they're not treated so well and about the pandemic. So the conclusion I'd like to put to you today is that doctors are facing enormous pressures in their work life, which has only been exacerbated by the COVID-19 pandemic. In response to these pressures, we should not only be asking how we can be assisting doctors to become more resilient, but also much more importantly, because we should not be blaming the victims, we should think about how can we make our workplaces safer environments where doctors are treated with dignity and respect, both junior doctors and senior doctors. What would that look like? Enforceable safe hours and rostering via an award that's proper. Permanent employment over fixed term contracts. Flexible working provisions to enhance work-life balance and particularly to support doctors with families. Part of that would be stronger parental and caring leave provisions. And just recently, there's been some changes in the legislation in New South Wales. We can't take any credit for that, but it's certainly very welcome. And we're certainly very thankful to the Ministry of Health for assisting that to get through the whole of government. It would also look like fair pay. The pay for junior doctors in New South Wales is the worst in the country. We'd like to see better protections against bullying, harassment, incivility. We'd like to hope that there will be ongoing management of staffing and PPE to prevent COVID transmission. This disease, this virus will be with us forever. How do we manage it? Staffing, PPE, vaccination, and I suspect that there'll be some sort of social distancing requirements for a long time to come until the vaccination rate gets high enough. There was a story in the Sydney Morning Herald just last week. One of the Scandinavian countries, an 80% double vaccination rate, had 25 persons on ventilators in an ICU. So it's about 6 to 8 million people, the same number of people as Greater Sydney. An adjacent Scandinavian country with 90% double vaccination rate had 0 persons in ICU and ventilators. So it would seem fairly clear the evidence is double vaccination and some social distancing will prevent lots of deaths and lots of dying, lots of persons in ICU. So the last point as to what the future might look like is suitable and safe office and workplace facilities. As part of the long-standing dispute between capital and labour, the government wants to put in place agile workplaces. Our members are strongly opposed to that. The evidence, the clear evidence in the literature is that it increases workplace stress, decreases privacy, increases risk of transmission of diseases, including the COVID disease, and the government is just not budging. It's all about the money. So we as a union are running as many cases in the Industrial Relations Commission as we need to send a message to the government. We do not want hot desking for senior staff specialists. Will we win that? We don't know. We put a lot of money into it, a lot of effort, but we will continue on and hopefully win that fight. So all of these things we're talking about need legally enforceable provisions in awards. And our view is that health services must commit to upholding these conditions through better staffing, better resources, better management, and thinking about their staff, not just about the bottom line. Thank you again for the invitation to this very important seminar.
Thank you very much, Tony. Thank you for very thoughtful and emotional speech. It's really made me emotional thinking about what stress medical professionals are going through. The overall pandemic has added on the already existing physical and mental stress, burnout, fatigue, and medical professionals are going through. And that further demands the urgent need of innovative changes and initiative needs to be done, not only at the individual level, at the organization level, so that we can look after our medical professional health well. Thank you very much. Now I would like to call Dr. Chris Dalton. Dr. Chris Dalton is President of Medical Benevolent Association of New South Wales. Dr. Chris Dalton is committed to provide comprehensive, innovative pool of ideas for clinical service delivery, integrated patient-centric care, and proactive clinical governance framework upon which is built a rewarding health system for all stakeholders. Please welcome Chris Dalton. Over to you, Chris.
Thank you very much, Dr. Raj, and thank you very much for the opportunity to the Mental Health Foundation of Australia. So, yeah, if we could, Anika, if you could open up my presentation, please. Thank you. So, I'm just going to talk about the Medical Benevolent Association and what we do for doctors' mental health and how that all fits in. We've heard a lot about the pressures on the medical profession and the particular stresses brought about by the pandemic. And the short message I wanted to put out there is that we're here to help. The Medical Benevolent Association is New South Wales based, but each state has their own, and certainly Victoria, where I think the foundation's centre has their own, a very active and strong medical benevolent. So what I'm going to say certainly applies to the state-by-state associations and the activities and functions that they fulfil. So the next slide, thanks, Anika. So we've been around for a long time. We were established 125 years ago. It's an independent charity run by a council of doctors, who I'll introduce a little bit later. And our essential function is to provide independent, confidential counselling and short-term financial assistance to doctors in their families in times of crisis. And mental health issues are certainly a very large part of those problems that face doctors and their families, which I'll detail later and show how we're helping with those. Interestingly, we just had a counsellor retire, Dr. John Allman. He's a retired orthopaedic surgeon in New South Wales, but probably you don't know him because he's been out of practice for some time. But his grandfather was one of the founding members of the Medical Benevolent 125 years ago, and we do have quite a long history of families and people who know each other coming on council, so it's a sort of robust line of doctors interested in the association. So next slide, thank you, Anika. We help families of deceased doctors, so sometimes doctors will die when without good insurance or not in a good financial situation. We help practitioners who are in active practice and their families, medical students and retired doctors, and sometimes non-medical people, occasionally nurses and things like that. We do have the authority to do that, but most of our support goes to medical practitioners and their families. Next slide, please. Our focus in recent times has been to support and help doctors through times of crisis. We've had a very strong focus on trying to improve the resilience of the profession and get doctors back on their feet, and we hope to help them manage, particularly financially, through times of crisis when they can't work, pay their bills, support their families when they can't work, and hopefully get them back to work. Occasionally, when doctors have died or they're just not going to get back to work, it does require some significant adjustment in the doctor's situation, even major decisions like selling the family home and removing children from private schools and that sort of thing, which can be quite devastating, of course, for families, but sometimes it really doesn't mean making major adjustments like that. But our aim generally is short-term crisis management and to get doctors back on their feet and in a stable situation so that hopefully they can work again. Next slide, thank you, Anika. We do have a strong counselling service. So we certainly wanted to promote ourselves to doctors under a lot of strain, particularly with the pandemic. Even if it's not a financial problem, we have 2 social workers who work for us and are available and very well trained and very capable with counselling. And I know a lot of the support we give is in that line. Somewhat surprisingly, we haven't heard a lot of problems directly related to the pandemic, such as overwork and stress and burnout and so on. But we kind of feel, because a lot of people have been working from home and things like that, we certainly have this feeling of the calm before the storm just at the moment. And we're sort of expecting, when things kind of settle down a little bit and we open up, that people are going to realise, and when they're backing off from the stressful situation a little bit, people are going to realise the enormous amount of stress they've been under. And we certainly want to promote ourselves as being here to help. We certainly give short-term financial assistance when people can't work, but between $10,000 and $20,000 a month, and there's a breakdown there of what we tend to pay for. Utilities are important, supporting rent, insurance. We support private health insurance when necessary. Sometimes we help with medical costs and registrations with medical board and colleges and training fees and things like that. So next slide, please, Anika. Just a brief overview of our demographics there: 60% female, approximately 40% male. Most here in Sydney, because of course that's where the population is. Some in regional New South Wales, and a smaller group in the ACT. And there's a profile there of the breakdown. Some students are in there, but mostly practicing doctors, and a very widespread of age groups there. So your next slide, thanks, Anika. Our referrals come from various places, including general practitioners and other specialists, hospitals, and sometimes the staff councils at the hospitals, medical colleges, employees, APRA, and sometimes the Medical Council of New South Wales, where doctors are brought for disciplinary hearings and it's felt likely they're going to be suspended or not able to work for a while. And we try to maintain a non-judgmental attitude and support those doctors and their families as well. And next slide, thanks, Anika. So this is sort of the crux of my presentation, I think, because it relates directly to what we're talking about. And it says only 14% of mental health there, but if you look at the other reasons for referral, in fact, most of those involve mental health issues. So really mental health is an enormous amount of the work that we deal with. The reason for the mental health being in its a smaller box there with only 14% is that's doctors who have had a specific mental health diagnosis that we're directly helping. And it's mostly, as you would imagine, anxiety and depression. Quite a significant number with bipolar disorder. That's the other one that comes up. I don't recall seeing anyone who's been diagnosed with schizophrenia or frank psychosis, although bipolar disorder can sometimes make people psychotic, as you know, and occasionally we have dealt with that problem. But by far and away, the main issue is anxiety and depression, as you would expect. But the other issues there, bereavement, substance abuse, work and stress issues, and relationship and domestic violence, of course, all those issues impact very strongly on mental health issues. So I think you can really say that sort of 60 to 70% of our beneficiaries and our referrals involve significant mental health problems, if not purely mental health problems. And next slide, thank you, Anika. We get only about 80 to 90 new referrals a year, and we support about 130 doctors a year. So we're certainly, I think one of the problems in the medical benevolent is we have been somewhat low profile throughout our history, and we are trying to improve that. Now we've appointed, as well as our 2 social workers, we've appointed an executive officer, and we have been a bit hamstrung, of course, like all organisations with the lockdowns, but her role will be not only to improve our fundraising, but to get out there and promote ourselves so that we can extend our services and make ourselves more available to doctors in need. And there's a breakdown of what we do. 30% is just pure counselling, so we do certainly get requests for that, and our social workers are very good at it. But the majority of what we do is direct financial support as well as counselling support. And next slide, thank you, Anika. And this is the council that does it. We meet, these are all volunteers and most actively practicing doctors and clinicians. We meet monthly to discuss our referrals, and we normally would get 4 or 5 new referrals a month, and we discuss those at length, working out what's required and judging what the doctor's requests are and their family's needs and so on. And we go into a lot of detail working out what's the appropriate way to support those requests. I'm president, and there's the list of other doctors there, but as I say, most are actively working clinicians. And John Allman's not there anymore as he's retired, but it was quite remarkable. A doctor in his 90s still helping us, and his grandfather, one of our founding members, but he's recently retired, and I didn't know he was as old as he was. He was so sharp. It was quite remarkable. Next slide. Thanks, Anika. So I hope I'm not inappropriately advertising us here when I know that the Mental Health Foundation is also looking for support, but of course this is the nature of charity. So, but I certainly wanted to promote our services more than anything else, and let people know that we're here to support, even if it's just for counselling, and that would particularly apply to young doctors under stress in the current environment. But it's possible to donate to as well. We have a website where it explains how all that's done. And next slide, thanks, Anika. And that's it. Yes, I'm all done. Thank you, Raj. So that's the medical benevolent, and happy to discuss or answer any questions about that later.
Thank you very much, Chris, for the wonderful speech and for the wonderful support you are providing to doctors and their family. Thank you very much again. So further, on 17th October, there's a virtual annual walk for mental health organized by Mental Health Foundation of Australia. And the foundation is also launching the mental health appeal to raise funds to develop program for prevention of suicide, for prevention of youth suicide. And there was, because we are running out of time and we are late, so I will skip the short video clip and we will directly go to the panel discussion. And may I invite Professor Bruce Tong to moderate the panel and invite all the speakers. So in addition, I would like to speak Dr. Ravi Kumar Kamishetty. He is an experienced orthodontist. So he's not looking after the dental health, but he's also an astute advocate of mental health. So please welcome Dr. Ravi Chi. Thank you very much, and over to you, Bruce.
Thank you indeed. Well, what a challenge we've got in this discussion. We've had a flood of questions coming in, and I've tried to organise these into questions about the individual, about their workplace and community, and also about organisational matters. So let's start with some individual issues as they've come up. And this, perhaps I could direct it initially at Elizabeth, initially, and then perhaps at Chris. There was a question about, and I think it came up from something that Raj might have said, where he talked about many doctors and other health workers seek to treat themselves. And Helen, in her talk about some of her interventions, talked about home delivered or online assessments and managements. And the question is, well, in fact, there are two here, which basically distill to, is there anything wrong with self-treatment? Or is this a good thing? In other words, should doctors and health workers be seeking to treat themselves? And if so, why and what are the alternatives? So perhaps, Chris, you might start with this, and then we'll seek Elizabeth's view and any others then that might want to comment on that.
Thank you, Bruce. Look, my personal view is no, it's a bad thing to do. And I think that the advice from the colleges and mental health experts in general, I have to agree, would be that it's a bad thing to do for a number of reasons. One is that doctors can be prone to inappropriate prescribing of drugs of addiction, and if they get into that hole, there's probably no better way to describe it. Of course, this can lead to disciplinary action. And the medical benevolent, we've had a number of those cases over the years where doctors have got into a lot of trouble with self-prescribing, particularly with painkillers and sleeping pills, and prescribing those for themselves and their families. With regard to somewhat more benign prescribing, so we're talking about maybe antidepressants and so on. Again, I think that's a mistake, because you certainly, treating depression and anxiety is much more than, of course, you would know, you're the experts in this area, is much more than just taking a pill. You need to discuss all that. There's a lot of sort of cognitive behavioural type techniques that are very important for managing depression, and having a good general practitioner or psychologist or psychiatrist, or all three of those, is essential for the appropriate management of those sort of mental health problems. And just taking a pill, and you can't hope to have any sort of objective perspective on managing a complex problem like that if you're just taking a pill and hoping it'll all be okay. You need someone to monitor the side effects and work, and particularly if you're not experienced in that area, if you're not a GP or a psychiatrist yourself, well, you're just not going to know what's the appropriate medication. And yes, there's all sorts of side effects and different things that can happen with different pills, as you well know. And it's very important to have an independent, non-emotive, objective doctor who's capable and experienced to manage all that for you. So look, the short answer is it's a very bad idea.
Thank you. And of course, but there then are issues of privacy, aren't there, I guess, which cover this. Helen, have you got any comment to make about this?
Yeah, first of all, I'd say it's not optimal, but certainly the evidence is that websites in our randomized controlled trials lead to improved depression and anxiety, and that self-management is possible. I'm not saying it's the best way to do it, but I think we have to remember many people can't get access to psychological help. Even access to your GP seems to be very restricted. During COVID, telehealth consultations went through the roof, and they're continuing and persisting. So talking face-to-face to a doctor through telehealth seems to be an effective thing. And I think into the future, we have to look at blended care models where you do digital combined with doctor interventions, because it's more efficient. It's just as effective if you're talking about psychological therapies. And it's the kind of way that our very slim workforce is going to have to be spread, I think. So I'd also add somewhat disruptively that most management of chronic disease is self-help. I mean, we do get advice from doctors, and we go and we get an awful lot of help and intervention when required. But for day-to-day management, people are managing their own health. And I think putting the tools in their hands to be able to do that is not a bad thing to be doing. So I'm sort of in the middle there. Thanks.
Thank you very much. Well, more could be said on that, I'm sure. Another individual issue that actually there've been a couple of questions. One is about substance abuse. There was a brief mention of that by a couple of you. And the other is more specific conditions like bipolar disorder, which stress can of course uncover, and their contributions to suicide. Now, I don't know who might like to initially respond to that. In other words, are these contributing factors to suicide? And if so, how can they in fact be dealt with as a preventive measure?
I don't know if I'm dominating here, but I'll jump in.
Yes, please.
Yeah, certainly mental health conditions are risk factors for suicide, and something like, depending on which country you're in, whether it's a Australian or a high income country, then often it's around 80 or 90% of people who have mental health problems have those identified in coroner reports post a death. In other countries, that's not the case. And indeed, if you look at people who die by suicide now, more than 50% of them have never been in contact with a health professional or for either a mental health appointment or for a physical health checkup. So we've got an issue here that's beyond diagnosing treatment. That being said, if you have good diagnosis and good treatment for bipolar disorder, that will reduce the likelihood that you will have a suicide outcome, obviously.
Thank you very much, Helen. There are a number of questions about the team in which the health professional works. And Teresa, you spoke very movingly about the lived experience of being in these teams, about the pressures, but also you mentioned the word team strength as being something that people were finding very helpful. There are a couple of questions about team strength, and I'll give the first part of it first. And that is, what are the elements which will build up a team, and how can a team become stronger to manage? I think that's a complex question, but there we are, and there's a follow-up after that. So if you could start, Teresa, and anybody else that might like to come in on that, perhaps Tony afterwards.
So a team needs to have clear leadership, but followership as well, and respect of all members of the team. And if there is mutual respect for all the team members, irrespective of their position, I think that goes a long way. And acknowledging each member of the team's contribution, so that people feel respected, feel valued. And I think then you find that as the team leader, when you ask people to do things and that, everyone just gets on board. I think the leader needs to lead by example. And you can't just, for instance, in the ICU team, you can't just sort of issue instructions and leave the pod and leave other people to do it. Everyone in the ICU team in the COVID pod gets involved in direct patient care. So respect, listening to each other within the team, good leadership, good followership, and one of the things is humor. It's said in intensive care, we have terribly dark senses of humor, but just finding some humor in moments of pressure and whatever. And that's not making light of serious things or something. That is just some sort of humor and whatever, and it just elevates the mood and helps us to go a bit further.
That's very interesting, actually. I mean, certainly in my world of children's hospitals and so forth, the visiting ward clown, the playing of music, and there is a wonderful series of music for children's hospitals. I think we can learn from that. Building up team strength, I wonder if you've got anything further to add on that, Tony?
Well, thanks, Bruce. Yes, the teams is interesting. We get bright people and we let them go through medical school, and they learn about anatomy and physiology and clinical care, and they learn about how to be a doctor in the real world in a hospital, but we don't teach them how to be managers or leaders. There's nothing. There's very little at an undergraduate level. There's virtually nothing at an immediate postgraduate level. So as employees, we are expected to have some understanding of management. Now, I'm a medical manager. I did formal training in medical management, but people become heads of departments, not necessarily because they're good leaders or managers, but because they were the last person standing, or they're particularly manipulative or narcissistic, and they were able to persuade people to appoint them as such. And as a union, we see all too often mid-career doctors becoming heads of department. They have no idea what they're doing, and it causes grief for everyone. So I think as a health system, we do need to focus more on leadership by staff specialists. And I think that is certainly something we need to do. And we as a union have been encouraging that for many years. But there is a small group that, of course, don't fit into these teams normally. In intensive care, you've got the senior consultants, you've got the trainees, but you've then got junior doctors who are just rotating through, and the same in all the craft groups. And this is a lost tribe. They're not part of any one of these teams. They may come into a term for a while. They don't know the people. They don't know the structures. Our previous medical rotation systems in hospitals were very happenstance. You didn't know what was expected of you in that term. There was no handover. There was no document telling you this is what we do in this team or in this term. These are the clinical protocols. Now, that's certainly changed over quite some years now with the postgraduate medical councils of various names in Australia and in New South Wales as heady saying, sorry, you must have a term description. You must get an orientation to that term. So we're certainly looking after our mid-career, sorry, our midstream junior doctors better. So they're no longer just interns, but they're not trainees in a craft group. So that's a group that are still a lost tribe. And that, of course, is the group that's got the greatest pressure. They're not in a training scheme. They're trying to impress. They're trying to fit in. We don't necessarily give them the skills to understand how to fit in, how to get into that craft group. And what's changed over the last 10 or 15 years, of course, is that with the lack of control over the output of medical schools by the federal government for ideological reasons, we've now got too many young doctors chasing the same number of craft group training schemes. In the old days, when I was a boy, you could generally get into the first or second or potentially even the third craft group training scheme of your choice. You can't do that anymore. And that's soul destroying. We are competitive people. You know, we were the best in our school. We may have been in the top half a dozen in our tute group or in our year, and we come out and we are not necessarily going to become a trainee in the craft group that we've put our hopes and aspirations into for 20 years. So teams don't help those sort of those people in between, the lost tribe. What are we as a health system going to do? I don't know. And the federal government seems unwilling to change the output of medical schools to stop the problem continuing.
Some big challenges in there, aren't there, about what about post-COVID, if there will be, when we move into an endemic situation. Thanks for raising that issue about orientation to any team. That's an important factor, isn't it? When you come into any group, there needs to be an orientation and transition process. Does anybody else have any comment about how we can build team strength, seeing this is obviously a very important factor in managing the stress, as Teresa has highlighted?
I would like to say, in continuations to what Tony has said, like, you know, there's no doubt the team is important and team strength plays an important role. But I just want to comment in that way where the training comes from, how the team is to be built, what are the qualities of a team, who should be trained at what level. Because what happens, like if we look back by the time doctors become specialists, it's around 15 years of training. And we expect doctor to be a very good team member. We expect doctor to be a very good leader. We want doctor to be a very good researcher. We want very good academician. We want doctor to be a good teacher. We want doctor to be a very good human being in total. We want doctor to be with a good communication skill. We want doctor to be a very good businessman also when it comes to private practice skill comes. But we are not teaching except anything clinical skills in 15 years of training. So rest of the part in the training part is missing. And that definitely reduces our capacity to cope. We expect the doctors to learn by their own, by hook and crook. And some doctor can learn and some can cope with it and some cannot cope with it. And that could be one of the reasons going into the easy mental stress and fatigue, because you're part of the system, but you're still not fitting into the system. And that's the important part. Changes needed to be done, I believe, from the training part. Thank you.
Thanks very much.
Bruce,
Yes, Teresa.
Teresa, just something that's a passion of mine and an interest of mine is simulation and education. And one of the things we do weekly, although COVID makes it a challenge, is routine interdisciplinary simulations where we get people off the floor. And that's the whole team, the multidisciplinary team. It's not just for doctors. And we focus not just on the clinical skills. There'll be some take-home clinical messages, but we also emphasize non-clinical or non-technical skills. And that's all about team functionality and communication and all of those things. And I've watched, as we've been running them for some time, and also just doing the simulations in a safe environment, it's helping the team get to know each other in a safe environment before they then go into the clinical domain. So that's just a little plug for non-technical skills in simulation.
Thanks, thanks, Teresa. That's a very, very positive suggestion, which could be taken forward. And there's a model that's obviously working. There is a corollary of my question, which has come from an individual who says something relating to teams, but it puts an interesting twist on it. He says the COVID has led my wife to become a member of another family, those she works with, and we feel we've lost her from ours, including the children. Help. That's a really incredible statement, and it's been alluded to by a number of you in terms of impact outside the workplace, in terms of when you go home, and its impact on partners, on children, which is one that certainly interests me greatly as a child psychiatrist. But I wonder if we've got any comment on that. How can we include the family system in this response? Because it's a vital contributing factor, isn't it, to the mental health of the individual and the wider community. Any takers?
I guess I'd like to make a comment if I could, Professor.
Sorry, it's Tony, is it?
Yeah.
Yeah, Tony, please.
I think it's understandable. To be very frank, I think it's important that occur. Yeah. It doesn't help the family. It doesn't, in terms of their interactions, but in particularly stressful times, you have to get on with your colleagues in the work environment. And if it assists you to cope, I did an ICU term, and I know what Professor Jacques was saying about dark humour in ICU. But you have to be able to cope with these things. And if you can cope better by having better interactions with your colleagues, then I think it's a very positive thing. Because if the interactions were poor, then you are at significantly greater risk of stress, burnout, suicide, getting one of these diseases. So I would think, even though the family may not like it, I think it becomes a very good adaptive coping mechanism to assist you to get through these terrible times.
Yes.
I alluded to the isolation from the family. The disease itself, COVID, necessitates a certain amount of isolation. And one of our staff members, I know for months, has been living in a caravan. She's got young children, unvaccinated, and she lives away from her family in the main house. It is very hard, and I think, but it's the nature of the disease. I think one of the things the system needs to do, Elizabeth's no longer online, but I think health managers and the health department, they need to acknowledge the impact of COVID work practices on families and family relationships. And I think some communication around that would be really good. And I haven't seen any forthcoming. And perhaps help staff with strategies they can use, helping your family understand why you're doing what you're doing, I think is very important. Why I have to have the swabs, why I have to separate for a while, explaining things to them, because there's lots going in, and Bruce, you're the expert, but the child mind has lots of things going on that they're not articulating, and they could be quite fearful about the well-being of their parent. So bringing that out into the open, I think, would be very important.
Helen, could I ask a question about your app in relation to that? Do you have any elements in that deal with parenting and with support of the family, which might in turn actually enable the person to work more effectively and retain their mental health in the stressful work environment?
Yes, there are sections actually of the website more than the app that deal with those particular issues, but I acknowledge that it is extremely hard to manage the family, and I understand from the questioner the perspective that this is really isolating the family from the parent. So yes, there are sections in there about how to explain how to deal with it, as Teresa has been saying, but I think it's a really hard one to get around.
It certainly is. I mean, we've got a bit of evidence from work on parent work with very stressed people in the workplace that, in fact, if they have an opportunity to discuss with their partner the management of their children who are starting to go off in their behaviour, that in fact that leads to a significant return to work of the person who is stressed in their workplace. So I think it's complex. Let's move on. I'd like to speak more on that one, but this is an interesting, moving away from the intensity of hospital situations currently, there's a question about what about the stresses in the community for health professionals, and is anything being done, or what should be done to help them? And I think Dr. Ravi, being a dentist in the community, you might have some thoughts about that, please. Well, you're muted still, Dr. Ravi. There we are. No, we're not hearing you, unfortunately. Perhaps we see if we can fix that. We'll come back to you, Dr. Ravi, with that question. I did have another one which resonates with what Elizabeth said about managing responses of visitors, and also links to you, Teresa, where you talked about workforce experiencing abuse from families or from people visiting. I think this is really quite an issue. Maybe, Teresa, could you start that one off about how this might be better managed, and others might have some comment about that too.
Is a challenging one. The principles of acceptable behaviour and that are displayed around the hospital, but of course, and this is, you know, for relatives and that, but of course they're not attending the hospital, so they don't get that introduction on what's acceptable and what's not anymore. I think making sure that families are communicated with on a predictable and regular basis is really important, and ensuring that the people who are doing the communication are as senior as practicable, because when they have multiple people speaking to them, they then start picking the conversations apart and saying, oh, I was told this, and then I was told this, and you don't seem to know what you're doing, and whatever. So I think regular, predictable communication at a senior level is helpful, and that hopefully that senior person, both medical and nursing, has the skills to diffuse any potential blowout of behaviours.
Thank you. Helen and Tony raised issues differently, but coming to the same matter, and that is what rewards can we offer our staff? You said you had ideas, Helen, but perhaps weren't going to discuss them. I might push you on that. And I think certainly Tony's definitely got some ideas on rewards to make the workplace better, safer, and more rewarding. Helen, are you game?
I just have a couple of comments, but as I say, I'm outside of the health system, so it's probably safe for me to make commentary. I don't want to say too much, but I do think that the communication has to be more forthcoming. You know, the public's been told the hospital system can cope, and the people inside the hospital are thinking, oh my God, what's coming next? You know, because it's, and so there is this disparity between what the political announcements are and what the actual reality is in the minds of the people in the hospital. At least my understanding of what talking to people, nurses and doctors in the hospital is. So I think, you know, the communication, I don't know too much about the idea of frontline workers as heroes. I think there's sort of a few nuances there that would need to be unpicked, but I think there has to be a greater promotion and strength by the community for regarding the sacrifices that have been happening by our healthcare professionals, because they're putting their families and themselves in danger. I guess the final thing I'd say, apart from we have to change the hospital system, which of course is just probably Tony's view, but I think recognition through payment isn't a bad thing to do. I think people are underpaid, they're being disrupted. Why not give people more money? You know, why not show that the recognition is there for the disruption of their lives, the extra shifts they have to do, how they have to accommodate the next change to practice in that hospital so that they're in a different ward or doing something else. I think from a perspective, you would have to actually find out what the rewards are that doctors and nurses and others would respect. But if you found those out, then I think they should be delivered straight away to this, to actually show the strength and belief by those working in those services that they do care and that they are really doing their best.
Thanks, Helen. Perhaps we're just with a view on time, I'll just go back to Dr. Ravi. Are you online now to just respond about what about stresses in the community?
Sorry to jump in, Professor Tom. Would Dr. Ravi be able to write the answer in the chat box and you can read it out?
All right. Thank you. Thank you. Well, I'm sorry we haven't managed to connect Dr. Ravi finally, because we have run to the end of our time. The last question, which is something we'll just have to think about, is this statement from Chris about the calm before the storm. And I think most of you have emphasised that we're in the middle of a crisis, a pandemic, but it's going to become an endemic, and we're all facing major issues around reorganisation of services, building up a workforce, creating a safe workplace, and in fact, working on new ways of promoting community mental health and well-being. Unfortunately, we have come to the end of our time. I've only just started. It's the tip of the iceberg, isn't it, in a way, with all the questions that are coming from this. We're going to move now to Teresa, who's going to propose a vote of thanks to you all for the absolutely brilliant and inspiring and challenging morning. Teresa.
Unmute. There we go. Firstly, I'd like to thank our excellent MC, Dr. Raj Killen. You've done a splendid job at this important event, and I'm pleased that we've kept very much to time. So thank you for your exceptional emceeing. On behalf of the Mental Health Foundation of Australia, the chairperson, Vasan Srinivasan, and the patrons and the board of directors and the entire team, because to put on something like this, there are IT people and organisational people working behind the scenes. And especially on my own behalf, a very big thank you to you all for sharing this event today. And a special thanks to all the speakers. These are busy times, and you've given up some time to be with us and share your thoughts on mental health for healthcare staff. Thank you to Elizabeth Coff, the Secretary of New South Wales Health. And I can tell you her schedule is unbelievably busy and ever changing. She's very grateful she's got the same health minister, because other things have changed in New South Wales. But thank you to her for giving up her time, and she's shown us that she actually cares for our health workers. A big thank you to our keynote speaker, Professor Helen Christensen. Thank you so much, Helen. I took a little screenshot of your last slide, which was, I think it's a very excellent plan for the future. Thank you very much for your talk and panel participation. And thank you to Tony and Chris. I've known Tony for many, many years, and been a member of Asimov for many years. And I thank him for telling us of the endeavours of Asimov in supporting, in particular, the junior medical staff, and also his personal statements about what it was like to be a clinician who now works from home. And Chris Dalton, thank you for your support of this event. Again, I've been a long-standing donor and fan of the Medical Benevolent Society. It is a society that helps medical professionals in need. It's confidential and anonymous and completely separate from bureaucracy, etc. And they do wonderful works. So thank you, Chris, for your time. Bruce, it's been an honour sharing this symposium with you, and it's a pleasure working with you on the board, as you are the patron of the Mental Health Foundation, and you're also an expert in the area, which I'm not, and I'm learning from you. And thank you to Peter, who couldn't be with us, but was able to provide that video of support. And our major sponsors, Australia Unity and Chemist Zone for supporting us, and they're enabling us to deliver a lot of sessions during Mental Health Month in October and beyond. So thank you very much for them. With the rising rates of mental health issues in the community, especially during these times, and we've alluded to what's going to come after these crisis times, the community is in dire need of a robust mental health support system now more than ever. I encourage you all to participate in other events, particularly that walk that's coming up on the 17th. Because by your participation, we are endeavouring to inform and involve the wider community to increase their awareness, education about mental health issues. The discussions of today, we've heard what the many issues may be, and we've heard some solutions, but clearly more work is needed to be done. So I hope the discussions continue. The Foundation would like to keep working with you all to make a remarkable change in the sector, with a positive mental health and wellbeing being a focus for our healthcare professionals. So thank you all, and we look forward to your continued participation and support.
Thank you. Thank you, Teresa. Sorry, I had a trouble that I have to join by phone. And anyway, we are near the end of our today's symposium. Thank you all for joining us today. Please join us in the mental health month events across October. And next key event is on 10th of October, the World Mental Health Summit happening virtually from 9 to 5 p.m. Also, Mental Health Appeal donation lines are open from 10 a.m. till 10 p.m. to take donations over the phone. And please donate. To donate, please ring 1-800-MHFA or just go to www.mentalhealthappeal.org.au. Thank you, everyone, and have a great day. Thanks for your participation.
Thank you. Bye-bye.
Bye.
Bye-bye.